So from lacrimal gland and accessory lacrimal gland, the tear production is there, and from there are two lacrimal papillae, one in upper lid and one in lower lid. From it is connected to vertical canaliculi and then horizontal canaliculi, which opens either commonly or differently also in lacrimal sac. And from lacrimal sac there is nasolacrimal duct, which opens in the inferior meatus of the nose. So what is dacryocystitis? Bedjo. Dacryocystitis is an infection of the lacrimal sac secondary to obstruction of the nasolacrimal duct at the junction of the lacrimal sac, or simply it's an inflammation of the lacrimal sac. It may be congenital or acquired. Now, congenital dacryocystitis, it is inflammation of lacrimal sac occurring in newborn infants, also known as dacryocystitis neonatorum. Etiology, it could be congenital blockage in nasolacrimal duct, membranous occlusion at its lower end near valve of Hasner, which is the most commonest cause. Clinical picture could include mild grade chronic inflammation with epiphora associated with mucopurulent discharge, positive regurgitation test, or swelling around the lacrimal sac. Differential diagnosis could be ophthalmia neonatorum or congenital glaucoma. Complications include recurrent conjunctivitis, acute and chronic dacryocystitis, lacrimal abscess, and fistula formation. Treatment: first, you should start with massage over lacrimal sac area and topical antibiotics if the patient comes at the first month, that is 3 to 4 weeks of age. If it is not resolving, then we'll go for probing of nasolacrimal duct with Bowman's probe after an interval of repeated massaging of 3 to 4 weeks. And if the probing fails, we'll go for balloon catheter dilation. If both probing and catheter dilation fails, we'll go for intubation with silicone tube. And lastly, at the age of 4 years, if there is no resolution of dacryocystitis, then we go for DCR operation. So, less than 2 months of age, lacrimal sac massage with antibiotic eye drop. For 2 to 6 months, lacrimal sac massage with antibiotic drops and lacrimal syringing. For 6 to 18 months, along with massage, probing, and for 18 months to 4 years, silicone tube intubation and balloon catheter dilation. We do DCR only after 4 years of age. Lacrimal massaging, it acts by increasing the hydrostatic pressure within the lacrimal sac and opens up the membranous lacrimal obstruction. It starts at the medial canthal tendon and gently massage downwards along the lateral nasal margin. Second is acquired or adult dacryocystitis. It may be acute or chronic. Chronic dacryocystitis is more common than acute. Etiology could be multifactorial. There is a vicious cycle of stasis and mild infection of long duration. Predisposing factors include age 40 to 60 years. Females have more chance of getting dacryocystitis due to their narrow bony canal. It could be hereditary, poor hygiene, low socioeconomic factors responsible for status of tears in lacrimal sac, which could be anatomical factors, could be foreign body or inflammation of lacrimal sac, could be obstruction by nasal diseases like polyp, hypertrophied inferior turbinate. So there are 4 stages in chronic dacryocystitis. The first stage is chronic catarrhal dacryocystitis. The only symptom is watering eye or sometimes with mild redness. Dacrocystography reveals a blockage in nasolacrimal duct with normal sized lacrimal sac and healthy mucosa. Second stage is lacrimal mucocele. It is with symptoms of chronic catarrhal. There is also a distension of lacrimal sac. It is characterized by constant epiphora associated with swelling below the inner canthus. A milky or gelatinous fluid coming from lower puncta on pressing the swelling. There is regurgitation of this milky or gelatinous fluid. On dacrocystography, there will be a distended sac along with a blockage in nasolacrimal duct. Sometimes due to chronic infection, opening of both the canaliculi into the sac can be blocked, leading to a negative regurgitation test. That is, this milky or gelatinous fluid will not come when we press the swelling, it is due to this encysted mucosal, because this canaliculi opening has been blocked. So if there is no canaliculi opening, the regurgitation of the fluid will not come, which is also known as encysted mucosal. And the third stage is chronic suppurative dacryocystitis. It is due to a pyogenic infection. The mucor discharge becomes purulent, converting it into a pyocele. It is characterized by epiphora, associated recurrent conjunctivitis, and swelling at the inner canthus with mild erythema of the overlying skin. On regurgitation test, there is a frank purulent discharge which flows from the lower puncta. If again there is the opening of the canaliculi are blocked, this pyocele will become an encysted pyocele. The final stage is chronic fibrotic sac. It occurs due to low-grade repeated infection for a long period, which ultimately result in a small fibrotic sac due to the thickening of the mucosa, which is often associated with persistent epiphora and discharge. On dacrocystography, there will be a very small sac with irregular folds in the lacrimal mucosa. Complications of chronic dacryocystitis could be, there would be a high risk of endophthalmitis if we do any intraocular surgery. Treatment, first we go for conservative treatment with repeated lacrimal syringing. If the case is very recent and there is no fibrosis or pyocele stage, then it can be resolved with repeated lacrimal syringing also. If it does not resolve, we will go for balloon catheter dilation, also known as balloon dacrocystoplasty. It is useful in partial obstructions only. Dacrocystorhinostomy, that is DCR, it is the operation of choice as it re-establishes the lacrimal drainage. Dacrocystectomy, that is removal of the whole lacrimal sac, is done only when DCR is contraindicated. Conjunctivodacryorhinostomy is done for blocked canaliculi. The second, after chronic dacryocystitis, there is also a stage called acute dacryocystitis. It is an acute suppurative inflammation of lacrimal sac, which is characterized by presence of a painful swelling in the region of the sac. Clinical picture include three stages, which is stage of cellulitis. It is a painful swelling with epiphora, fever and malaise. The second stage is stage of lacrimal abscess, in which there is a large fluctuant swelling with lacrimal abscess and pus point. The third stage is stage of fistula formation. The fistula can be external or internal. Etiology, it can be an acute exacerbation of chronic dacryocystitis, which we call acute on chronic dacryocystitis. It could be an acute peridacryocystitis due to direct infection from paranasal sinuses surrounding bones, dental caries, dental abscesses. Complications of acute dacryocystitis could be acute conjunctivitis, corneal ulcer, lid abscess, orbital cellulitis. Complications could be acute conjunctivitis, corneal ulcer, lid abscess, orbital cellulitis, ethmoiditis, and rarely cavernous sinus thrombosis. Treatment for cellulitis stage, systemic and topical antibiotic and systemic anti-inflammatory analgesic drug. For stage of lacrimal abscess, we have to do the drainage of the abscess. For external lacrimal fistula, after controlling the infection, fistulectomy with dacrocystectomy or dacrocystorhinostomy has to be done. The surgical techniques for DCR, it can be done with conventional external approach or endonasal approach or endocanalicular laser DCR or DCT. Conventional DCR. For conventional DCR, the blood vessels in the middle nasal mucosa are constricted with ribbon gauze or cotton buds, lightly wetted with 1:1000 adrenaline or cocaine 4 to 10% solution. A straight vertical incision is made 8 mm medial to the inner canthus, avoiding the angular vein. Anterior lacrimal crest is exposed by blunt dissection and the superficial portion of the medial palpebral ligament is divided. The periosteum is divided from the spine and the anterior lacrimal crest to the fundus of the sac and reflected forwards. The sac is reflected laterally from the lacrimal fossa. The anterior lacrimal crest and the bone from the lacrimal fossa are removed. A probe is introduced into the lacrimal sac through lower canaliculus and H-shaped incision is made to create two flaps. Membranous obstruction at the common canalicular opening or distal canalicular obstruction can be opened by excision or trephine of obstructing tissue. A vertical incision is made in the nasal mucosa to create anterior and posterior flap. The posterior flaps are sutured. Silicone intubation can be performed. Interior flaps are sutured, and then finally the medial canthal tendon is resutured to the periosteum and the skin is closed with interrupted sutures. So basically what is happening, the nasal lacrimal duct is obstructed. So you have to create a passage from the sac directly to the nasal mucosa. So this DCR surgery is that opening from the lacrimal sac to the nasal mucosa. So it is incised, an opening is made and the flaps are closed. So complications, intraoperative complication could be excessive uncontrollable bleeding, diplopia due to damage to medial rectus or any extraocular muscle. Blindness can occur due to damage to intraorbital vessels or optic nerve, all the very rare complication. CSF leak could occur due to penetration of cribriform plate, injury to the orbital contents, injury to canaliculi. Postoperative complication includes SUMP syndrome, which may occur if the rhinostoma, that is the opening from the sac to the nasal mucosa, is small and very high up in the lacrimal sac, which causes tears and mucus to accumulate in the sac and discharge into the eye. Ocular orbital lesions like orbital fat exposure, persistent watering after the DCR surgery may indicate there is a scarring of the rhinostoma and which require the operation. Orbital hematoma, subcutaneous emphysema, CSF leak, air regurgitation, dry eye or failure of the DCR surgery. Complication associated with a silicone intubation if it is done with part of DCR, pyogenic granuloma, retrograde migration of the tube, corneal irritation due to the tube, soft tissue infection, adhesions, elongation or erosion of the puncta, migration of the tube and traumatic injury to the nasal septum. Another approach for DCR is endoscopic DCR, in which a slender light pipe is passed through the lacrimal puncta and canaliculi into the lacrimal sac and viewed from within the nasal cavity with an endoscope. The remainder of the procedure is performed via the nose. The mucosa over the frontal process of the maxilla is stripped. A part of nasal process of the maxilla is removed. The lacrimal bone is broken off with piecemeal and the lacrimal sac is opened. Silicone tubes are passed through the upper and lower puncta, which is pulled out through the ostium and tied within the nose. So in external approach, so the advantages for endoscopic DCR, there will be no external scar. It is a relatively bloodless surgery, less chances of injury to ethmoidal vessels and cribriform plate, less time consuming, and no postoperative morbidity. For external DCR, the success rate is much more than endoscopic DCR. It is easily performed by ophthalmologists. Although endoscopic DCR could be performed by ophthalmologists, but it is mostly done by ENT surgeons. For external DCR, there would be no requirement for expensive equipment, does not require familiarity with endoscopic anatomy. Disadvantages of endonasal DCR: less success rate, requires skilled rhinologist or ophthalmologist, requires expensive equipment, require reasonable access to middle meatus and familiarity with endoscopic anatomy. For external DCR, there would be a cutaneous scar which could be visible, relatively more bleeding during the surgery, potential injury to adjacent structures, and requires more operating time. And the laser DCR, it is performed with a Holmium YAG or KTP laser. It is a relatively rapid procedure which can be carried out under local anesthesia. Therefore, particularly suitable for elderly patients. However, this is about 70%. Other methods could be balloon dacryocystitis, recanalization with endodiathermy. So dacryocystitis, the indication for dacryocystitis or DCT are for lacrimal causes, could be lacrimal sac tumors, atrophic lacrimal sac, tuberculosis of lacrimal sac, or if there is very severe dry eyes. Other causes could be atrophic rhinitis, Crohn's disease, ocular pemphigoid, or SLE. Local or general anesthesia is given. Skin incision, a curved incision along the anterior lacrimal crest. Medial palpebral ligament is exposed along with anterior lacrimal sac. Ligament is cut with scissors and anterior lacrimal crest is exposed. There is dissection of lacrimal sac along with removal of the whole sac. Then curettage of bony nasolacrimal duct is done. Closure is done with the suturing of medial palpebral ligament to periosteum. Orbicularis muscle is sutured with 60 vicryl and the skin is closed with 60 silk sutures. Conjunctivo-canalicular dacryocystitis or Lester-Jones tube. A DCR is performed as far as suturing. It is done for canalicular obstruction. So, DCR is done for nasolacrimal duct obstruction. So, if there is canalicular obstruction, we do conjunctivo-canalicular DCR. The caruncle is partially excised. A stab incision is made with a graphene knife from a point about 2 mm behind the ulnar canthus in a medial direction so that the tip of knife emerges just behind the anterior flap of the lacrimal sac. The track is enlarged sufficiently with dilators to allow the introduction of a Pyrex Lester-Jones tube. The incision is sutured as for a DCR surgery.